did email you the case study and I emailed you the additional RAM information, but it's also in your your module.
Okay.
Okay. Please mute if you have kids in the background. Thank you. All right. So stimulus, okay, focal. This is that change or the stimulus that immediately confronts the person. So remember I said if you were walking and you fell and you busted your head, it's that busting of the head that's going to cause me to adapt now to what's going on. Because now maybe I was going to the store, you know, I don't know, going to a baseball game, whatever. Now I got to go get my head sewed up, right? But not only that, it's traumatic. Maybe not even as traumatic to me as the people around me. Also, it could have other outcomes besides the busted head. I could end up with a neurological issue. You know, other things could occur. So it's that thing at that moment that brings me to the emergency room. Now, think about it in your patient. How many of you read the case study and how many of you read the additional information?
I did.
I read it.
I did.
So what's going on with the patient right now that brought him to the ER?
His levels are elevated and
Fatigue, weakness.
Okay,
He was
so
coughing up blood.
okay, so there's a few things going on, right?
Yep, he couldn't breathe. Chills.
And the patient has some pretty significant history of other medical diagnoses, right? Like
Mhm.
diabetes, gout,
Hypertension.
hypertension, okay? They're in renal failure. We know in renal failure, they could be retaining waste products. They could be a lot of different things going on. They could be retaining acids. If they're retaining acids, what could be the outcome of that?
Breathing problems.
Okay, they could end up on a ventilator.
Mhm.
They can end up in acute respiratory distress because we talked about the kidneys, right? And I said that the kidneys help the body compensate for when that balance is off. So kidneys aren't working in this patient.
So they can go on dialysis.
They may have to go on dialysis. You know, a lot of different things can happen to the patient. Now, if you read the additional information, you're going to find a lot of stuff on there that you need to include in this care plan. So you have to read that, because if you don't, you're going to give me a rough draft and it's not going to have the information on there that we need on there. It's going to be incomplete. Okay, so your focal stimulus will also go down in the bottom of your care plan, where right next to the objective. So it goes in that slot between the objective information or objective behavior and between that nursing diagnosis and goal slot there. Y'all know where I'm talking about?
I'm trying to look for it.
yes.
Let me see if I can pull up a care plan.
Is the patient goal outcome short and long?
I got to stop my share for a second.
Oh no.
Okay, so in here is going to go focal, okay? In the middle, conceptual. and then residual. So focal is the immediate thing that brought the patient to the ER at that moment, okay? It should be something urgent, and that's what your priority diagnosis is going to be directed towards, because it's that immediate issue that caused them to change, okay? It won't be something that they might resolve over a couple of years, okay? It won't be something like their diet or something like that, because they've been eating a wrong diet for years. They didn't just start eating this wrong diet. That's why they've got high blood pressure. That's why they've got gout. That's why they're a type 2 diabetic, okay? And all those things need to be in the medical history, by the way. Recurrent kidney infections, and this patient has gotten to the point, this is non-compliance to its max, okay? They had their toe amputated. What do you think that was caused by?
Diabetes.
Diabetes.
Sure, and it could be a combination of that diabetes and that gout being out of control. Allergies, some people missed the drug allergies. They only put the food allergies on there. Some people put that the skin was intact. The skin's not intact. If you read through, you'll find out it's not. So patient social history is on the addendum sheet. Now, I don't want word for word what it says, so don't cut it and paste it into the box, okay? When you put in social history, first of all, Islamic religion is the religion, and that goes under Erickson's stage. The body image, that goes under Erickson. So do you think this person has a body image problem? They had an amputation.
Yeah, he would have, yes.
Okay. And what stage of Erickson's disease in? So those three things should be in there. You should address the body image, you should address the religion, and you should address that Erickson stage. What role is this person? Okay, what role is he currently at in his life, or what role is he going to be transitioning to now? So I would like to know what he is now and what he's going to be transitioning to.
You mean like as far as like the caregiver, the independent role?
Sure. What is he?
Okay.
Is he a paternal role? Is he, just a single self-serve? Is he involved in a community? What kind of role does this person do on an everyday that these changes would affect his life? That's under psychosocial, and I'm sorry, I said social history. So if you go above there, all right, to the second column here, this is your social history.
Yeah.
All right, your medical history is going to go there. What's code status on the patient? It's in there. It's right, it's clear as a bell in there, okay? Vital signs go here. You don't need to put them at the bottom unless something's abnormal. That's part of your objective finding because they're already here. Pain level. All right, so this O2 is if your patient's on a nasal cannula, okay, you're going to put however many liters he is, all right? And then it's liters per minute. And then in the via, you would put NC if it's nasal cannula. If it was a face mask, you would put that. If it was a non-rebreather, you would put NRB. If it was a, what's the other one? Venturi, you would put that. All right. Lung assessment. What does its lungs sound like? They're not clear throughout. What did they sound like?
Crackle.
Okay. How about the cardiovascular assessment? Put it in there. The skin status. I want to know what it was like. Did he have a wound? He did. And it's not a hemodialysis wound. There's another wound there. So all these little categories, and believe me, for all these, I went through the case study and I went through the information, so I know this information in my brain. So if it's not there, I'm going to recognize it. And when you get your paper back, it's going to be in red. Hey, go back and check this out because you didn't read that well. So just make sure you get all them columns. Okay, now what's your biggest part that you don't understand?
Under,
The
where it says,
last page.
Go ahead, one at a time.
where it
Would
says.
would unmarried be under past social history, or we don't
Yes.
need that? Okay.
Unmarried would go under social history. You would need that. Why? What does that tell you if someone's not married?
The support system.
Sports
If
is
they have
independently
family.
caring.
Okay, they may need some additional help, and he's an Islamic man. So what does that, what kind of additional complexity does that add to it? He's going to feel funny about certain people taking care of him and all because of the religion, right?
Women
But they
nurses.
have some stigma about that. All right. What else? Who else has a question?
Where it says under neurological function and senses, what do you want for senses?
What's it say in the
It says review cranial nerves, okay, and then senses.
So if you go back and look, some of that's documented. Now, if
okay.
there's nothing, absolutely nothing documented about his senses, then you can put NA.
Oh,
But
okay.
if you put NA and I see something documented, then you'll get gigged for it. So I
Okay.
got a keen eye for care plans. That was my specialty in nursing school. Even though it was 20 years ago, I still got it. I have to use care plans every day at work. My nurses have to make them up for every patient that comes through the door, and they're on every one of my floors. They're not the greatest, but they make them because they have to do it all by hand. We don't have a care plan system like a hospital.
What's an MMSE score?
Mental status, mini mental status. And I don't know if I gave you guys the mini mental status form, but you don't really need it because they probably have it listed here. If they don't, then don't worry about it. You put NA.
Okay.
Okay,
And then
because you can't see the patient. You really can't do it unless you want me to send you the paper and you want to try to calculate it off of the documentation.
No,
You're not going to get extra credit for it.
we don't want that.
No.
No thanks.
Nope.
Michael's going to do it and he'll tell everybody else to support. All right, what else?
Hi, I'm sorry, I just want to clarify something. So all we have to do is make a care plan following this rubric for the chronic renal failure case study. We do it individually
You
or
do
as
it
groups.
individually, and you have to make sure you have the case study and the addendum.
Okay, when is it due?
The rough draft is due Saturday. Okay, if you don't send the rough draft in by Saturday, then I may not get a chance to do revisions on it. And trust me, you want me to do revisions on it. Because if you don't get the revisions in on time and you get locked out, then you won't pass it. And this is a pass-fail for the course. If you don't pass this, you don't pass the course. I expect these things. When you get done with this, it should be full. You saw how mine was in the video?
Yes.
Boxes should be full. Now, for your lab and diagnostic studies, guys, you only have to put the abnormals.
For the diagnostics also?
Yes, for the lab and diagnostics, just put the abnormals in there.
Okay.
And for the labs, you want an explanation as to why it's abnormal, correct?
No, I just want you to put the lab and the abnormality. Like if it's showing, renal failure, I should be able to see that with the creatinine and the BUN, right?
Mm-hmm.
If you did an x-ray and it showed pneumonia or it showed gout or it showed something like that, I would want to know that.
So you
If
said-
your blood culture and the white blood cell count was elevated or the hematocrit or hemoglobin was elevated, I would want to know that.
So the abnormal ones for the labs, you're saying? Okay,
Yes. And the diagnostic studies.
all right.
Ms. Lewis, just one thing. When you're typing in the spaces, it's actually, would you be able to see everything? Because when I'm typing in my information, it's just like going under the line hidden.
So when you click on the box, though, you can see it, right?
Yes.
Yeah, usually I can. Once you send it over to me, I can just click on the box and it populates.
Okay.
One thing that you could do is save it when you're done. I would hit File and Save As. And I would save it as a read-only file to send to me.
Okay,
And then I can either type directly on it, or if I can't type directly on it, I'll send like a summary sheet with it saying, hey, fix this, or I'll highlight it or whatever. But the reason why I'm saying hit Save As and send me the copy that you make is because this way you retain your original and I don't mark all over it. Because sometimes when I mark on people's originals, they can't undo it when they get it back.
okay.
Just food for thought.
Question. Can
Yes.
we scan it to you? Like, can we like print it and write on it and scan it to you, and then you can edit it that way, so we don't have to mess it up when we type it?
Nope, it has to be typed because I can't manipulate it if it's not.
Okay.
And people have sent me handwritten ones in the past. It's just a pain. It's a real pain. And then you still have to type it out in the end, because when it gets loaded into Canvas, I won't accept it if it's handwritten. Everything's, computerized now, technology at its finest. So I wasn't even allowed to handwrite my care plan. I had to type it in a typewriter in one of these forms. It was crazy. Not like what y'all got. All right, teaching and discharge. Okay, let's talk about this. All right, so let's say my nursing diagnosis is, what was the one I gave you guys on ineffective breathing related to excessive fluid. What the hell was the one I gave you guys for cardiac? I'm sorry. Let me look it up. It's hard just to ramble a nursing, a good nursing diagnosis off the top of my brain. I got too much stuff on my laptop, and then you try to find something. It's like, yeah, okay. How you guys doing on those RAM projects while I'm looking for this? Has everybody gotten a chance to meet with their groups, figure out what they're going to do?
Yeah.
Yes,
Yeah.
they're coming along.
Okay.
Yeah.
We're going to go over a lot of stuff tonight for the midterm. So the game plan is once we get done going over this care plan, I'm going to talk to you guys for a second about the midterm. And then we're going to go through all that. I have to go to a meeting at 8, and I have to meet with a couple students after. I'll try to come back on after that if you guys want me to. And I also plan on doing a review on Saturday. That'll be questions though. Tonight I'm trying to go over notes and lecture points. And then Saturday it'll be questions, and I plan on doing another session either Sunday night or Monday night. It'll probably most likely be Monday though. Okay, so you could do something like decreased cardiac output related to congestive heart failure as evidenced by dyspnea or shortness of breath upon exertion, pulse ox of 89%, increased respirations. So you have that full nursing diagnosis. Now, you're going to have to do the same thing for renal. So what's going on with the patient? And think about what is the priority nursing diagnosis here. What brought the patient to the ER? What's really going on with them? What's the seriousness of this? So when you do your discharge teaching, all right, if my thing was decreased cardiac output related to congestive heart failure, well, one thing I would want to teach the patient is to weigh themselves daily, right? Patient should learn to weigh himself daily and report signs and symptoms of fluid volume overload or weight gain or exacerbation of congestive heart failure. I would want to refer this patient to PT/OT. I would want to teach this patient how to eat a proper cardiac diet. I would want to teach this patient how to do pursed lip breathing in order to control their shortness of breath. So these are the types of things that should be under my teaching and discharge needs. Discharge needs also include any referrals that the patient may need once they leave the hospital. So if this patient is really sick, when they come out of the hospital, you're going to set them up probably for some sort of home health care or some sort of rehabilitation. And then, you know, everything's going to be still correlated around that nursing diagnosis because it's that focal stimuli that brought them in. That nursing diagnosis is married to that focal stimuli. In other words, they should be, one should be connected with the other. Then you want to have 5 interventions that are towards that decreased cardiac output secondary or related to that congestive heart failure. So what kind of nursing intervention could I do for this patient? Okay, well, one thing I could do is teach them how to use the incentive spirometer. I could give them their ordered furosemide to help remove some of the fluid. I could put them on a fluid restricted diet as per the MD order. And you need to put the rationales for why I would do those things. So if I were using the incentive spirometer, I'd be trying to expand the lungs and maybe improve the shortness of breath. Same thing for the pursed lip breathing. If I'm trying to take that fluid off, then I'm trying to help expand those lungs a little bit more because that fluid is causing the diaphragm to press up on the lungs, or there might even be some of that fluid in the lungs. And that may be altering the lungs' abilities to exchange gas, and you're altering the tissue perfusion as well. So, you know, what kind of things can I do to improve that, what that diagnosis is? All right, now goals. All right, a goal for a patient with decreased cardiac output due to congestive heart failure might be for the patient to lose 1 to 2 pounds within 2 days of hospital admission. Okay, now doesn't that cater to what else I said? Because I want them to lose fluids, I'm putting them on a fluid restricted, and I'm giving them Lasix or something along that line. So you see how everything goes together. The goal has to be specific and measurable. Is that a specific and measurable goal? Sure. I can weigh the patient to see if he lost weight. And I said it has to be done within 2 days of admission. So that gives me a time frame. Now for my evaluation, okay, 2 days from now, I'm going to weigh the patient. Let's say the patient only lost a ½ pound. So now I'm going to say goal not met. Fluid restricted diet initiated, Lasix initiated, maybe it wasn't enough, but we wanted to go in slow because we're concerned about the patient, all right? So, you know, goal was partially met, but not all the way met because the patient only lost 0.5 pounds and my goal was for him to lose 1 to 2 pounds. And you have to say that in the evaluation statement. And now Where did I get this nursing intervention from? So I need to put either an internet link there that takes me right to that intervention. When I click on it, it should go right to that intervention, not to some page that has nursinglabs.com with 40 ways to write a care plan for congestive heart failure. Or you could take the intervention out of the NANDA book, and you could just write, you know, the author and the name of the book and the page number, and that's just as good. Now, non-observable. These are things the patient tells you. I'm short of breath, nurse. You can't measure that. You can, but not here. We're just saying you can't see it. The patient's telling you that. I sleep on 2 pillows at night. Okay, you're not going to see that unless you're in the patient's home or they're with you at the hospital. But they're just coming in, so they're going to tell you that, right? When I walk, I get short of breath really fast, or I huff and puff, I can't breathe. I have to sit down. I get dizzy. Observable. Well, for one, the pulse ox, maybe it's 89%. The patient's having retractions when they breathe. The chest doesn't rise and fall symmetrically. We can see that edema, or that fluid volume sitting on the skin, on the belly. In the stimuli here in the middle column, focal, contextual, all you're going to do is cut and paste from what you took up here. So my patient has congestive heart failure. He went to the hospital not because he had an increase in his shortness of breath. He has shortness of breath all the time, but today there was an increase. So he felt it more than usual. That was his focal stimuli, that increase in the shortness of breath. And now his heart is racing because he can't breathe well. So it was the tachycardia and the increase in the shortness of breath that brought the patient to the hospital. All right. The conceptual stimuli is that the patient is non-compliant with their diet. They had a heart attack 4 years ago. The ejection fraction is only 39%, so the heart's not pumping that great to begin with. Patient eats a lot of salt. So those are things that can affect, that cause, that lead to this increased shortness of breath. He had a weight gain of 5 pounds in a 24-hour period. All right, residual. Residual is, here is my renal patient that you guys are doing, right? That you're doing a renal patient who's on a strict renal diet, okay, that he doesn't follow, by the way. He's sitting up here in the hospital, okay? Now, how many of y'all know that food equals what?
Food?
Yes,
I know
what does food equal?
What do you mean equal?
So when I give somebody food, what am I giving them? Am I giving them something?
Energy,
Nutrient.
Huh?
Nutrition?
Nutrient.
Life.
You ain't giving them nutrition.
Water.
What do you?
Life.
I don't understand.
Love. You're giving
Pounds.
them comfort. You're giving
Comfort.
them,
Life.
Oh yeah.
right?
Only if it's fried
You're giving
chicken.
them, right? When your husband or your wife come home and they see that nice dinner you done prepared for them on the table, they got that big smile on their face, right? You know that the food you're giving them is killing them. What happens if you don't make that kind of food? What happens if you come home, they come home after working 8 hours and you got a salad sitting up there on the table? I ain't no rabbit.
They don't want
I'm
that.
trying to get you that rabbit food.
If it come with grilled chicken on it or grilled salmon, they'll still be happy. It's the equivalent.
Yeah, okay. You tell me now, who's gonna sit up there and eat some broiled chicken over a great big fried chicken dinner, a steak? Because I'm not.
Not my spouse either.
I'm sorry, but if you put a fried chicken dinner there on one side and a broiled chicken dinner on the other, yeah, the broiled chicken dinner is going to the homeless. Just gonna say that right now. All right, because I can't do it. I like those fried fatty foods because they have the flavor. And so you bring that flavor. Why? Because what does that flavor remind you of? When you cook, who do you try to cook like?
Oh, your mom.
Grandma. Your grandparents.
Exactly. And a lot of us tend to cook the way our in-laws want us to cook, right? Especially women, because your mother-in-law gonna come in the house and she gonna be like, this is what my boo needs to eat. You're gonna try to keep the peace, and your boo gonna want you to be like his mama, because he's gonna pick a girl that's like his mama. That's what they do. Right? They mama 5 foot tall with a big old booty. That's the kind of girl they gonna end up with. So, you know, the food is about the comfort and the love, and that's the point I'm trying to get to. And when your patient's sitting up in a hospital and they're non-compliant, and you're bringing this rabbit food, this hospital food that's good for them, right? What are they going to turn around and say to wifey or girlfriend or the kids?
They sneaking food in for them now.
Yeah, because they starving me to death here. Nobody feeds me. They don't care about me. And they're going to lay the guilt trip on. So your patient may stay non-compliant in the hospital. So those kind of things are residual effects. Okay? The patient, it doesn't really realize that it's affecting, and sometimes they do, but sometimes they don't really realize that it's affecting their health overall. And it may not necessarily be the patient who doesn't realize it. Like the family can sometimes be in denial. Like, you know, we're not killing daddy. So what? We gave him 50 pieces of fried chicken last night. We're not killing him. So, you know, that's what your residual is. What other things could be residual? Your gender, your age, your race, because they can play a part on your health that sometimes you're aware of, sometimes you're not aware of. Your genetics. So that's what residual is. All right, medications. You got to put the medications, you got to put all of them that are on the sheet that they're currently taking. Okay? The dose, the frequency, the route, and any nursing considerations. So like if they were on Coumadin, what would be a nursing consideration?
Bleeding.
Bleeding precautions. Bleeding.
Okay, bleeding
Clotting
precautions,
factors.
checking that PTINR, taking the medication at the same time every day.
Will every med have a consideration?
Every med has a consideration. Every med has black box warnings pretty much. Okay, so that's it for that part. Anybody have any questions there?
Ms. Loach, I have a question.
Yes.
I know that you went through all this explanation with the residual. So when it comes to the plan of care, what do you want us to add there on the age or the type of food he's eating?
So I'm not going to tell you what I want you to put there because I want you to think about what you should put there.
Okay.
I gave you the concept,
gotcha.
Okay, of what I want you to put there. I want you to think about it though, and then figure what you should put there.
All right. Thank you.
Just trying to see if I have one on the, there it goes. No, it's okay. So for my cardiac patient, what I had on mine was that they were African American, that they were 79 years old. I think I had the religion on there too. They were Baptist. So, you know, there were certain things on there that are going to affect culturally wise.
I have a question real quick, just because I think I'm a little bit confused. So are we turning in a renal care plan or a heart failure care plan?
I'm using heart failure because I don't want to give you the answers.
Oh, okay. No, I'm just making sure I'm not confusing the information. That's fine.
So, well, when I showed you guys the practice care plan, I used the heart failure plan. And the reason why I did again is because I don't want to give you the answers, because I want you to think.
And even our rough draft, it can't be written out. We have to type it in.
Yes, ma'am.
Okay.
It won't take you that long to type the stuff in, trust me. Once you do it, you'll be glad it's done. Okay.
Do you have a hard copy of that? Oh, you don't want to give us a hard copy of the your cardiac care plan?
The sample one? Yeah, you
Yeah.
can have a hard copy of that. It's cardiac, but don't give it out to people, okay? Because I might use that again later.
Yeah, I just need a guide. Like I have the idea, but I'm just like missing certain things. So I just want to make sure I'm in the area.
Just remind me before we sign off tonight to email it to you. Okay.
Yeah.
So everybody understands the residual, the contextual, and all that good stuff?
I think so.
Ms. Loesch, could you send, oh, you already put something up. Could you, you know that, it's either that, the residual, yeah, that.
This one? Okay.
Yeah.
So I think I already sent this to you guys.
Yeah.
So check your email. I sent you something called Care Plan Tools.
Yeah.
I didn't see that, but I'll double check.
Okay.
All right, sorry.
Sent it this afternoon.
She just sent it today. She just sent
Yeah,
it today, but
today.
like a few hours before class.
Yeah.
See it, okay. I'll double check. Thank you.
Okay. All right, so next thing we're going to talk about real quick is the midterms. Okay, your midterm is next Wednesday. It's from 4 p.m. to 6 p.m. You have to be on that computer and ready to sign in with the exam already downloaded at 3:45. I would download the exam on Tuesday. It should be there. On Tuesday, if you open up your computer and it's not there, then reach out. All right? Make sure by no later than Wednesday morning, if it's not there, you let me know because we got to get it up and running. I don't want to wait till 4 o'clock. If you wait till 4 o'clock, you lose exam time. The exam's not done and it's not uploaded by 6, you lose the exam. You have technical difficulty in the exam at all, okay? The first thing you're going to do is call IT. While you're calling IT, send them an email. Have somebody help you. And then send me an email. Stay on the phone with IT and send me an email. I'll already be working on it at my end. But if you get there at 4:16 and you can't download your exam, I can't help you.
Ms. Loesch,
It already should have been downloaded, okay? Yes?
for the first page on the case study, where it says clinical site, what do you want us to put there?
Oh, it doesn't matter. That stuff doesn't matter. The
And how
date,
about date?
put any
How about
date.
date? Any date?
Any date.
Okay.
Ms. Loesch,
Clinical sites there because when we were doing these, they were actually doing them on patients at the clinical site.
Okay.
I'm sorry, somebody else had a question?
yeah, so next week, as long as we download it by 3:45, we okay. But we can start the actual test at 4.
Download that exam at 3:45, Mama. I want you to download it the day before.
Okay, yeah, I did that. But what I'm saying is we don't have to
Make
officially.
sure we're all on the same page there. Then
Yeah.
at 3:45, you're going to open up your computer and you're going to start looking for that passcode.
Okay.
Make sure it's charged. Make sure your internet's working. All that good stuff.
Okay, no, I just thought it was something different. So I was getting a little nervous because I'll still be at work.
The time is different, and I know that there's a lot of emails coming out, and some people were asking me about coming to the school. You guys are not coming to the school, so I just want to make sure everybody understands that.
So what is that? So actually, I just got an email and it says a new assignment, in-person testing video.
Right, but that's in case you have to go in and do any in-person testing.
Oh, okay. All right.
Right now, your exams, unless I tell you otherwise, okay, will not be at the school. Only the nursing classes that are higher level are going to be testing at the school. And I'll actually be at the school while that's going on. All right, so everybody understands. Make sure your computer's charged. Make sure you download the exam the day before if possible. If you get there the night before, Tuesday night, and you don't have an exam there, pick up that phone and call me. And send me an email. Always have that paper trail.
So I have a question for the, because obviously we have midterms in other classes. So for our Monday midterm, are we downloading that like Friday or Sunday, or like do we know when that will be?
Sunday. Yeah, you should get
Sunday?
that by
Okay.
Sunday. Yeah.
Okay, so it'll be the day before for each midterm. Okay.
Yeah, I believe it's supposed to come out a day before so you can download it in advance.
Okay.
All right, anybody have any other questions about the midterm? Midterm is on chapters 1 through 7 and 13 through 18.
One through 7 and 13 through 18.
Yes.
How many questions?
100. It should be 100 questions.
Ms. Loesch, if this midterm was like on campus and this was like pre-pandemic, was y'all giving out this many chapters at a time for the nursing program in general?
Absolutely. Nothing's changed as far as the course itself, other than the fact that it's online. Okay, so I just got to pull up one more thing, and some people were interested in knowing the average for the exam, and then we're going to talk about the top 10 missed questions, okay? And then I'm going to give you guys your code, and anybody that wants to leave is free to leave, but I am going to be reviewing for the midterm tonight. I just want to let you know that.
What time are you gonna review for the midterm?
I'm going to start as soon as I get done here, and then I have to go to my meeting at 8, and I have to meet with the student after that, and then once I meet with that student, then I will be back available, and I also will be doing a review on Saturday and either Sunday or Monday. I'm not sure yet which.
Is Saturday going to be the 12 to 2 again?
It's going to be 12 to 3. It's 12 to 3 on Saturdays now, but I'm not doing math this Saturday.
Okay.
Because it's going to take too long to go through the reviews and all, and everybody should be pretty decent on math. If anybody needs any additional assistance, then just let me know, and we'll go through it.
Ms. Loesch, I have a question.
Yes.
Is it possible to turn the care plan in after the midterm exams? Because it's
rough draft?
Yes.
I mean, here's the thing with the rough drafts, okay? The final care plan is due 10/4. So as long as I have to check them, time to check them and give them back to you, yeah. The problem is people don't listen to me, and they don't put what I tell them to put on there, and then they send them in, and if you don't have certain stuff on there, it's not going to pass. So it's for your benefit to really try to get it in as early as you can, so that this way I have time to really review it and give you the correct answers.
Much to do about
I just want to verify, you said that the care plan's actually due on October 4th, which is a Sunday? Okay, just making sure.
The final draft is due October 4th.
Okay, thanks.
So Ms. Sue, you're saying it is okay to give it to you after the midterm?
Yeah.
Okay.
And if you give it to me after that and I don't get to review all of them, that's on y'all, not me.
Oh.
I should, but you know. Let's see, your midterm is when? What date?
Next Wednesday.
Wednesday.
Which is what date?
23rd.
The 23rd.
23rd.
The 23rd, and then the care plans are due on 10/4, so that gives me 2 weeks to check them and get them back to you, and you to get them back to me. It might be doable.
Yeah, I kind of like that. Even if you said no later than Thursday, I like that better than Saturday because we have the time to study.
I mean, so you need all the prep
chapters.
exam.
Oh my gosh.
And this exam is like 35% of your grade.
Yes, Miss.
It's a big
Oh,
Hey,
my.
Mizu, we are not doing only L to R. We're
Yes,
doing
Michael.
English
Come,
and other.
Michael.
What he said.
I got a little, you see my little violin here?
Uh-huh.
Playing it?
Miss Lowe, you were a nursing student too. No.
I have been a nursing student multiple times.
But when you said that, did you see the class perk up? The class perked up. Like,
yes.
Like, you feel so
Wait.
overwhelmed.
Wait, so what was said now? When is it due? Just to be clear?
So
Next week after the meeting.
I need a rough draft by no later than next Saturday, okay?
Yes.
Next Saturday.
Thank you.
Yeah,
we have it now.
Thank you.
Yes.
So now we're ready to talk. Let's talk.
Yay.
And you want to
Feel the
have a
energy.
question for the exam?
Energy's changed.
Miss Lou, I'm ready to talk now.
Yes, everybody's talking now.
I have a question though. Are you going to be able to get to all of those though? Like you from what I understood, you said if we get it to you by Friday or Saturday of this week, you guarantee that you'll be able to give feedback. But if we choose to do it after the midterm, there's a possibility we won't get any feedback. And this, if we don't pass this care plan,
We're
we
gonna
won't pass this
pass.
class.
Britt, that's not what she said, Britt. That's not what she said.
That's why I'm asking. I need to understand.
So no, we
Everybody got excited, and I need to understand what's going on.
Yeah, if
That's
you
true.
get yours
That's a good
available, you
question.
can
I'm
put
not
in.
gonna hang you out to dry. I don't hang people out to dry. That's not my style.
Okay.
As long as everybody turns it in on Saturday, I will get them all graded.
Yes,
Okay.
thank you.
Okay, thank you.
It doesn't
Appreciate that so
have
much.
anybody
But
on
give
my
us
for the care
feedback,
plan.
right?
I can look
Yes.
at those care plans and tell you in a second if it's what I
Yeah.
want.
Yes,
Miss
my
Loge.
problem solved.
Yes.
Miss Loge,
Yes.
I know you said that you'll grade them, but if we would have did it this Saturday, we would have gotten feedback. So if we give it next Saturday, are we still going to get feedback to revise?
You're still going to get feedback, but your time to revise is going to be less
Okay.
because
Okay.
they're due on 10/4. The reason
So
why I
then
give
we-
people
let's
so
look at
much
a calendar.
time is because
See if we
people
plan this out.
sometimes get lost with all that. All
Okay,
right?
so if we give it next Saturday, the 26th, then we have that following week.
There we go. Hold
Yeah,
it.
because we,
The 4th is a Sunday, so we have that following week to get it done.
It's just
Okay.
revision. You're not starting from scratch.
No, I'm aware. I'm just trying to see
the more-
how much
you
time.
know, the more stuff,
Yeah.
and that's why I'm saying the paper should look full when it comes to me. The
Okay.
more stuff,
Okay.
and not full of garbage, you know, full of everything that's on those 2 pages.
No, that's more than enough
Okay.
I
time.
guess that's why I can't find it. I'm in the wrong doggone box.
Thank you. Oh my gosh.
Okay, I was trying to give you guys your average for the exam, and I couldn't find it, but now I think I know why. Because I'm talking and not paying attention, and I'm like looking in the wrong spot.
Is there any review for the exam?
Yeah, we're gonna do a review tonight, and I'm gonna do a review.
Do you
Saturday.
get to see the exam we took?
You do not get to see the exam.
No, not you, not us, but you. Did you get?
Nope, I don't get to see it either.
Oh wow.
Yeah, I get to see the top 10 questions, which we're gonna go over.
Okay.
That people miss, the top 10 that people miss.
Okay.
Okay, so your average for campus for the evening class was a 76 on the exam. You were in the top 2 classes for the exam. Just so you know.
How many classes are there, Miss Sue?
1, 2, 3, 4, 5. And you guys tied with another campus.
I was about to say, because if it's 3.
For second.
Right.
No, you guys tied for second for that.
Oh, okay.
Not too
Wait a
bad.
minute, what was it? What did you just say?
I said you tied for second.
So any reward for that?
A
Class
reward,
average.
your reward is that you're going to be a great nurse. That's your reward.
Yeah.
Your reward is hopefully one day you'll be an instructor like me, hopefully. Not necessarily to a bunch of students, but to the people who you're mentoring, who respect you, who come for you. Okay, let's talk about the questions real quick, and then we're going to move it on. Oh, that's why I didn't look at the questions, because I got to put that stupid code in. Everything's a passcode.
Miss Loesch, I have a quick question.
Yes.
For, just for the care plan again, with the medications, where the nursing considerations are, can we use, like if we have a drug guidebook, can we use that?
Yeah.
And do we have
want
to just...
you cutting and pasting into the squares. Like I want to see your own words in there. So I don't care about for like the interventions and stuff like that. Okay. But for like when you're putting in like the residual and the contextual stuff, the psychosocial, that kind of stuff.
Okay.
I want to see your own words in there. But like for the interventions, you can cut and paste in there as long as it makes sense.
Okay.
Don't just throw anything in there because it sounds good.
Okay.
Ms. Loesch, I have a question. I want to confirm that the prep viewpoints are going towards our midterm.
Yeah, that's what I want to ask.
So yes, for every exam except for the final one.
Okay.
The prep views are lined up with it. So it should tell you in your syllabi what prep view chapters are lined up with what exam. Now, here's the way prep view points work. And I told people this from day one, but you have to really pay attention to what I'm saying. If you have 3 chapters, let's say you have 14, 15, and 16 assigned for the midterm. And I don't know what chapters are assigned for it, okay? Because that stuff I don't keep memorized. It's
15, 16,
no value
17.
to me. But whatever it is, let's say you only level up to 5 on 2 of them. You're not going to get the points. Now, if you don't level up to 3 at least, you're going to lose points. If you only go to a 3, you're going to get a 0, which means you get no points added to the exam, but you don't lose any. You want to get points, you have to level every chapter to a 5 before the due date. That's going to get you 3 points for the exam.
Question: if we get an 8 on all 3 of them, does that make a difference? No, we still get 3 points.
It doesn't make a difference. Where it makes a difference is you'll probably get a better grade on the exam than somebody who went to a 5.
Okay.
Because unless you're just clicking and memorizing, all right, if you're retaining the knowledge and comprehending the knowledge the way you should be, leveling up to an 8 is going to get you those harder questions, those critical thinking questions, the things that you really need to know to be a better nursing student, to understand this information.
Okay.
Oh, top 10 can't be that far down. Where are those doggone codes? Let me do one thing first. Let me give you guys your codes. Hopefully everybody's going to stick around now, because the information I'm going to be giving out tonight is going to be valuable. Your code this week is UP, UP, UP. Now I know why I can't find them, because they're not even named that. So now I got to look for this weird name. Okay. Did everybody get the lecture notes and the other stuff that I sent?
Yes.
Yeah. Yep.
Yes.
Oh, got it. Okay.
Serious?
Okay, so the first question that that the majority of the class missed was a K-exalate question. Do you guys remember that? It was K-exalate 35 MEQs ordered for your client. And it was K-exalate 60 MEQs per 50 mLs. Do you guys remember that? It was a math question.
I think that was the second one.
Yeah.
Is everybody good with the MEQs now? With doing the math on it?
Yeah, but can we do that problem? Can we go over that?
Yep.
Thanks.
Okay, so the order was K-exalate 35, and it's written as MEQs. Okay, so that should be a small. Don't let these little values trick you guys up, okay? This is a simple desired over need question, okay? So you have this K-exalate 35 MEQs. It's ordered for your client, and what is available is 60 MEQs per 50 mLs. And it's asking you to calculate how many mLs you give to the client, and you're going to round it to 1 decimal place. So you need 35. The MEQs doesn't really matter. You have 60 per 50 mLs. So you just take the 35, because that's your desired dose, divided by 60. I do have a master's, you can't tell on here. What's that equal when you take 35 and divide it by 60?
Oh.
0.58.
0.58.
Okay.
333.
So you have 0.58, and then you multiply that times 50.
And it's 29.
29.2?
1.
29.1 what?
29.16. 29.2.
You should round it up to 29.2.
That's correct.
Yeah.
That's correct. 29.2.
Oh, yeah.
Okay?
Oops.
When I did it, I thought we had to convert the MEQs to milligrams. That's what I thought.
So let me just let me see if I can pull these questions onto there so you guys can see them. Or let me see if I can actually just open up my Zoom here. Might be able to just open up my Zoom here so you can see the questions. Since the rationales aren't there, I should be okay for sharing them. So, okay. Seriously, computer. Come on, let me end the Zoom. So annoying sometimes. Let's see if it's going to let me do it now. Okay, so that was the first question. Can you see it?
Yeah.
All right, second question. The nurse reviews a list of tasks to delegate to UAP. What should the nurse do first before assigning the task? So the answers were identify the right task for the UAP, ensure that the client is stable, provide instructions to complete the task. D is incorrect, all right? And E, ask the client if it's okay, is no. You don't do that either. Anybody have questions about that? Number 9, it's the nurse's response.
Wait, no, I had a question.
All the way up there.
Okay.
So when it's saying provide instructions to complete the task, and I'm pretty sure this is one of them I got wrong. And that's probably why I got it wrong. I probably left that out off of there because I probably was looking at it as to the effect of like us teaching the CNA when most of the tasks that you delegate to the CNA is things that they're already, you know, already within their scope of practice, like checking a weight, a daily weight, or, you know, giving the patient a bed bath or assisting with feeding, something, to that nature, or was I reading into that wrong?
So here's the deal, okay? First of all, don't compare your nursing questions to real life, because that's going to get you wrong every time. You see, it happens to me all the time when I'm doing questions with you guys, right? Because I'm always thinking in real life scenarios, and you have to think textbook, okay? So the reason why you have to give instructions is because let's say that you want the UAP to get a blood pressure, okay? Or something along that nature. You have to give them clear, specific instructions. Can they monitor a blood pressure? Yes, but only if you say, I want you to take so-and-so's blood pressure, and you can't say, come back and tell me if it's abnormal. You have to say, take so-and-so's blood pressure for me and come back and let me know if the diastolic is over 100 or if the systolic is over 150. You cannot just go take a blood pressure for me. You have to give them clear, specific instructions. So that's why it's saying that. That's textbook. Real life, you may not do that. But
okay,
if the UAP did something wrong and you're the charge nurse and you gave them an order and they said that you did not give them instructions, you could be held liable for that.
Okay, so basically just cover your own ass.
Exactly.
Okay. I was just reading into that wrong. That's all. Okay, thank you.
Okay. Anybody else? All right, number 9, it's the nurse's responsibility to know the Nurse Practice Act in his or her state. Standards of care, regulation of practice, and the American Nurses Code are not laws that the nurse should refer before initiating treatment. What are universal guidelines that define appropriate measures for nursing interventions? And that's a standard of care. The nurse explains informed consent to a client who is scheduled for heart bypass surgery. Which of the following are elements of the consent form? So you have to disclose any issues about the procedure that the client might need to know, like potential risk for harm, all right? You also would have to disclose to them if there's something else less invasive that might be able to help them. You also would have to make sure that they comprehend what you've said to them. So, a lot of times when we do teaching, we have the patient teach back to us what we've said because you want them to understand fully and have full knowledge of what you're about to do, especially for something like this, bypass surgery, because they're going to be taken off. Their heart could stop. They're going to be taken off of their heart for a minute and put on this artificial heart lung. So potentially, if it doesn't go right, they could die.
I think this was the question where there were 3, the competence, comprehension, and disclosure.
Yeah, absolutely. I remember that too.
Yeah.
That we had talked about last Wednesday after the exam, where we were only allowed to choose 2.
Okay, well, I'll look at this one and see and make sure that competence is an answer. So you guys feel like this one's marked wrong. You feel like competence should be included.
Yes.
Yeah.
Yep.
I think in the book
Yeah.
it was
It says
yeah.
competence, comprehension, disclosure.
Competence was everywhere.
The book says.
But when I did this question, even though competence was in there, I picked A and, well, I don't know if it was A and D in the test, but I did the best 2 out of the 3 that I thought. But confidence was in there.
Too. Yes, that's what I did, and I chose A and D, but the E was in the textbook too.
Okay, I'm going to look at it. It's number 11. It won't let me highlight it. But
Thank you.
let me take a picture of it because it won't let me highlight it. Okay. 2 children need a kidney transplant. One child of a famous sports is one is a child of a famous sports figure where the other child comes from a low-income family. What ethical consideration is relevant to the nurse as an advocate for these clients?
Miss Sue, I did pick A, but I was torn between A and C. And the reason why I was torn between considerations of power, because I was looking at it like, you know, when you're a famous figure, you have power. So, you know, like I was looking at it like that. Like, okay, I mean, we wouldn't look at it like that as a prudent nurse, but that's how I was looking at the question.
Okay. So, you know, the nurse is advocating for the client. So the problem with the kidney is, you know, this is a problem with organ transplant. I mean, there's a lot of hospitals and stuff that actually sell the organs, even though they don't admit to it. California's had an issue with this and a couple of other states. So it is a problem. And it is a problem when people have power, but in this case, it's the cost effectiveness and the allocation. Now, one thing that you have to think about with the kidney is once it's out, you only got so much time to get that kidney to somebody before it's going to die. And I actually have a patient about 10 years ago that was developmentally delayed who would have never gotten a kidney, but he got a kidney that day because the kidney was supposed to go to California and it missed a plane. And so they had nobody else to give the kidney to. That was a match. This kid was a match. He got the kidney. In any other circumstance, he would have never gotten a kidney because he's developmentally delayed. There is no true separation there. You know, there's still a lot of disparities. We're working on it, but you know, we know that it's something that happens. But before you go and fight for one person versus another, you want to make sure that you're able to get the resources, because if you fight for the kidney and then you can't give it to the person, right? Now everybody's lost out. So you just want to make sure that, you know, whatever you're doing, that it's feasible.
So what you're saying is that because the person has money, they will have, it will be easier for them to get it?
Not necessarily. Again, we don't know where the kid is. The kid could be at the hospital where the kidney was available. Because it could be a kid, you know, in like a children's hospital that's there sick and needs a kidney, right?
Yeah.
We don't know if the kid has money or not. If he's in children's hospital, that doesn't mean he has money. That's a public hospital, right? So all it's saying is you would consider if it was cost effective and if it was feasible to get the kidney, you would definitely want to advocate for the person in the low income family if those two things were feasible.
Okay.
You know, people do strange things when it comes to organ donation. I had a patient that had neuromalignant syndrome, and I don't know if you guys know what that is, but he had a very high temperature, 107, a pleural effusion. He was schizophrenic patient. He was on psychotropic drugs and other drugs for years. He went into the hospital. He was on life support. We were getting ready to take him off life support. I usually go to the hospitals when my patients are about to die because I know these guys for a long time, and I'll do like their final care on them and all that stuff. And I'm down there with the guardian, and you know, the organ donation people are calling us. Like, I mean, they're really calling us on the phone, like bugging us. They want the organs from this patient. And you know, me and the guardian are talking. The guardian's not a family member of this person, and we're like, really, why would they want this guy's organs? I mean, he's to me, it doesn't ethically make sense knowing the type of hard drugs this guy's been on his whole life for his issues, and now he's got all these other critical care issues. The organ's got to be damaged, and now you want us to consent. We're going to take him off of life support, and you want us to consent. So after we declined giving them the organs, and I went back to my facility, they actually called the facility and they lied to the facility, and they almost tricked one of my nurses into faxing all the paperwork over there. My nurse got in a lot of trouble over that because they gave HIPAA information and everything over to the phone to this organ donation place because they made them feel like they were part of the hospital. And it was all scheme just to try to get those organs. Really got to watch it with the organ donation thing. All right. I'm sorry. Back to the subject. I would just want you to understand how important that it is and things that can happen. All right, nurse exemplifies the professional value of altruism. What behaviors recognized by others demonstrate this concept? So the nurse arranges for the interpreter for the client that does not speak English. The nurse notifies the healthcare provider that the client reports pain medication is ineffective. Questions on that one?
Select all that black killing.
Yeah.
Come on, mouse. All right, what examples of meeting physiological needs according to Maslow's hierarchy of needs? How many of y'all remember this one?
I did.
Yeah.
Yeah.
I took B and C over sleep. 'Cause I was thinking nutrition is more psychological need over sleep.
Well, I would look at B as more of a self-esteem sort of issue, self-actualization, that kind of thing. I mean, they're overeating, so there may be something there esteem-wise, in my opinion, but, and then D was the other one?
Select all that appears. Yeah, apply. It's tricky.
Well, it's asking physiologic needs.
Yeah.
Okay. So you have to go with just the physiologic.
That's true.
What are the proper nutrition? Nutrition too is part of the physiological.
Because it says they're counseling an overweight teenager, it's talking about self-esteem, not physiologic. Because if you're overweight, you have enough nutrition.
Okay, yeah.
Okay.
Can I ask about A? Is it safety?
Yeah, I put.
Yeah, I think I put A too because I think that's important. You gotta
Yeah.
watch your
I
hands
thought it
and
was
food.
physiologic.
Yeah.
It's safety.
No, it's not.
Be under safety.
Yeah,
That's a safety.
I would have to look at it and pull up the Maslow's thing. I don't think so, but I'll look at it. I'll take another look at it just to be on the safe side.
And even though it says physiologic needs, you gotta remember that it's Maslow. So you gotta result
Physiologic
back to
needs are
Maslow.
more of your basic needs right now: oxygen, rest. Okay, the basic needs, and that's not a basic need, right? Sterilization before procedure is not a basic need. I mean, your patient might get an infection, might die from it, but.
Oh yeah, it's from domain 11, safety protection, risk for infection.
But isn't safety the next one up?
Well, yeah.
On the needs?
A is listed under safety protection.
I thought with the Maslow, the next level is safety.
Or they
Yes,
have
it's
to
security.
the physiologic needs.
That's confusing.
I don't believe that A falls under physiologic, but I'm going to look at it. Okay. All right, the nurse, don't forget, like a lot of people look at these, so, but I'm going to take another look at anything that you think you may have seen in your book, just to make sure, because you have a right to know if it was right or wrong. All right, the nurse is providing primary prevention education to a group of clients. Which actions by the nurse would indicate primary prevention? So smoking and nutrition, okay? Rehab is tertiary. C is tertiary and B is considered secondary. The nurse is applying evidence-based practice during wound care. What characteristics of evidence-based practice does the nurse demonstrate? All right, so she's using the problem-solving approach. She uses the best evidence available, and she blends the science and art of nursing. All right, traditional is C, and institutional protocols don't necessarily all meet evidence-based practice, especially some of the older institutions. Okay, so these blended competencies, all right, these are a set of intellectual, interpersonal, technical, ethical, legal capacities that we need in order to professionally practice as nurses. So you should be able to describe things like thoughtful, person-centered practice, what a nurse's expected personal attributes should be, what kind of knowledge base should the nurse have. And that's really going to depend on what level of practice she's going into. What are your blended and QSEN competencies? You should understand clinical reasoning, judgment, and decision-making and how to use it. Also, the person-centered nursing process and reflective practice that helps you become a better person and nurse. So a thoughtful nurse is somebody who's considerate and compassionate, and you keep the patient at the center of everything in order to promote humanity, dignity, and the well-being for that particular person. As a professional nurse, you have to obtain certain personal attributes, like mastering the science of nursing. So that's why we say don't study just for the exam. Develop the blended and those QSEN competencies. Those will help you promote thoughtful and effective patient-centered care. Personal attributes that you should have include like open-mindedness, so non-judgmental, having a sense of values yourself, being ethical, self-awareness and knowledge about your own beliefs and values. So if you have some sort of prejudice against someone and you're in the room and you're allowing that prejudice to be present, then you need to remove yourself from that situation. Because if you can't go in the room and take care of somebody, and prejudice can come in all sorts of ways. It doesn't just have to be race. Some people don't like big people, obese people. Some people don't like people that are too skinny. Some people don't like people that are too hairy. Some people don't like people that are Jewish. You know, it doesn't have to be a race. It doesn't have to be a religion. It doesn't have to be a culture. It could be a lot of different things why you don't like that person. And you have to be able to set those behaviors aside in order to give that person the best possible care. You have to be able to motivate yourself every day and give the best that you can give to people because they entrust themselves in your care. So you want to be ethical. You want to have that empathy, and you want to have that passion when you go to take care of those patients, and let them know that their well-being is in your best interest, that, you know, their best interest is in your heart. Leadership skills also, and you have to have enough bravery to question the system. So if something seems like it's not working, or there's something you see that can improve care, you should step up to the plate and say, hey, let's do this. So we aim to manage each patient's care. We do it scientifically, holistically, and creatively. We also have to consider cognitive, technical, interpersonal, ethical, and legal competencies. And we have to be willing to use those competencies, creative and critically, when we're working with the patient to help promote or restore that level of health, to help prevent or make that illness a little more tolerable, and to help that patient cope with that altered style of functioning. Because that's really when your patient starts to feel it, is when they can't do what they used to do. Or, as I say, when it takes me all night long to do what I used to do all night long. All right, so nurses want to practice that person-centered care. They're committed. They want to have that professional relationship, which is based on respect and trust. It's a holistic approach. It's consistent with theories that are based on human caring, and it promotes humanism, health, quality of living, where caring is viewed as universal, and it's practiced through these interpersonal relationships. So nurses use those skills, and they're able to establish powerful partnerships with both the patient and other people that they work with. They're able to deliver this person-centered care through the processes that are holistic and tailored to meet the individual need of the patient. So the ANA's definition of nursing is providing that caring relationship that provides health and healing. Also, attention to the human experience, their response to health and illness. And that's really what RAM or what Roy talks about, is how people respond to illness or health. How do they adapt? How do they function once they've been hit with this and they can't go back to the way they used to function sometimes? With the patient's physical and social environment. So when they get healthy or when they get sick, they're in that dynamic. If that dynamic also goes away, so if their social environment changes or their physical environment changes, it could cause them to adapt even further and have a whole nother type of experience. We have to integrate the data that we gather, all right? We use knowledge, and we have to appreciate the patient or their experience. That's really how you use empathy. It's when you don't go over the top, but you understand and you kind of put yourself in the patient's shoes. Some nurses are really mean to the patients, and they don't really seem to care anything about the patient for some reason, because they're tired or they feel overworked or whatever the case may be. So you're going to apply that knowledge to the process of the diagnosis and treatment, and through the judgment and critical thinking. So people are unique. Each person has their own set of beliefs. They all have their own emotional, physical, social, and spiritual dimension. So everybody's needs are going to be individual. So when somebody's sick, like the way one person responds to a disease, you can't expect everybody to respond that way, because they're not going to. Everybody's going to respond different. And it could be based on other experiences that they've had throughout their life, or what they know about the process, or the lack thereof, the lack of knowledge thereof. Sometimes people don't take care of themselves because they lack the knowledge to properly take care of themselves. So we use that assessment data with the knowledge, and we apply that scientific knowledge. We want our nurses to be professional. And in order for you to be professional, you have to be cultivated. You have to have the mastery of science. You have this clinical experience, all right, that you develop through these blended competencies, which are those technical, cognitive skills, and the other two. I forget what the other two are, but we'll see them in a minute. And then you have these blended competencies and the QSN competencies that promote thoughtful and effective person-centered practice. All right. Yes.
Are we supposed to be looking at PowerPoint?
Oh, I'm sorry. You're not seeing nothing?
We don't see nothing but us.
I apologize. Thank you.
You're welcome.
Not that screen, no. Where's the other screen? Thank you.
You're welcome.
Okay. So you want to have this professional knowledge. As a professional, you influence society and you influence public policy. You also can help promote justice. And sometimes you could do this just as being a nurse, or you could actually become a lobbyist and you can go into politics and do this. Also, you're trying to make sure that we provide safe and quality evidence-based practice, all right? Because that makes sure that we don't really do any harm to our patient. For reflective practice, that's when we start thinking about our own awareness, all right? Our own biases, our own judgments, our own prejudices. How do we think and how can we improve that? Or how can we make ourselves better so that we don't have to exclude ourselves from working with certain people? And then good clinical judgment and reasoning, decision making. You need to have this process. So it's not just memorizing the questions and memorizing the answers. You really have to understand and comprehend what you're reading and really get to know the human body inside and out, so that when you're taking care of your patient, you don't do any harm. Because if you only half know it, it could be a little dangerous if something happens to the patient and you're not really sure what's going on. So you go with your gut, but your gut's wrong. So when you really learn the information, you really understand it and you really comprehend it, you can use this clinical reasoning to analyze the situation, make a better judgment, decide on your alternative possibilities, okay? And then choose an action to be taken based on everything that you've evaluated and analyzed. And then we have this foundation of knowledge. We have a certain amount of experience, and that builds into that clinical reasoning and judgment. And then, you know, we want the person-centered practice, okay? This describes the way that care is organized through actions that are taken in response to the individual needs of the patient. So the components of the nursing process are used. So we're going to use ADPI for this. This is evolved around the nurse, the person being number one, of course, the reflective practice that we just talked about, using the clinical reasoning and the judgment and the decision making, taking a response to that individual's clinical need, and all that together makes the person-centered nursing process. The healing action that occurs in response to the individual need will complete the cycle of a thoughtful practice. So once we have completed the whole cycle, then we can say that, you know, what we did was good, is valued, it was effective, it helped the patient ultimately. So these are just things we just talked about. Just go over them, learn them. You should know what each one of these things mean and how they affect you as a nurse. So for person-centered care, we use a few principles. One, all team members are considered caregivers. We need that continuous healing relationship. The care is going to be customized to the patient's needs, values, and choices. The knowledge and information are shared among people that are taking care of the patient, as well as the partners, physicians, and other caregivers. Care is provided in a healing environment of comfort, peace, and support. Family and friends are also essential part of the care team. If the patient is not able to articulate preferences, they might need some sort of surrogate to help them make decisions. How are you going to communicate with these people, and how are you going to provide information and support they need if they're not able to speak for themselves? Patient safety is the priority. So safety measures like hand hygiene and other protocols preventing hospital-acquired infections, medications, and other errors, as well as falls. Transparency, that's the rule, all right? We want to be transparent with our patients. That means we're going to tell them the truth. Let them know what's going on. Keep them in the loop. Does your patient have the information they need to make an informed decision? If not, how are you able to help them with that? Also, all caregivers have to have a common focus towards the best interest and goals of the patient. So that's going to help us to take care of that patient better. The patient is the source of control for their care, because ultimately, if they don't agree and they don't like what you're doing, it's just a waste of time anyway, because they're not going to be compliant with it. Sometimes your patients will only be compliant while they're in the hospital, because what happens? They get sick, they get scared, they go to the hospital treats them. Oh, I'm never going to do that again. I'm going to do blah, 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 blah. And 3 months later, what do you see? Hello, internet world.
They'll be back in the hospital.
They come back in the hospital.
Right, because as soon as they start feeling better, they start the same old crap again, right?
Yes.
Like an abusive relationship with your body. You keep going back for the torture. Okay, so caring is the human mode of being. A lot of people have lost that human mode. They don't care. All right, they don't care about you. They don't care about even themselves sometimes. We have to be caring as nurses. It guides us morally. It guides us ethically, spiritually. If you don't care, you don't belong in this business.
Well, the doctors are already mindless zombies, so we got to give the care.
Oh my gosh, that was so good.
Mindless zombies, she said.
When I meet a doctor and they're actually nice, I'll be so surprised. It'd be like, oh, you're saying good morning to me? Oh, good morning.
Yeah, I don't have that problem. My doctors are always on my door, like 24/7. Sue, we need you.
Well, when you're the manager, they got to come harass you. Y'all got to build a rapport and have a great relationship. But the little people that running around, they're just minuscule to them.
Well, remember that you said that, and never be one of those people that makes people feel like little people. Because, you know, it's not a nice world to be in. And doctors can be a little bit, you know, that way sometimes. You know, I went to a doctor's office one time with my partner, and it was after bariatric surgery, and I noticed the doctor was washing his hands, which is something I never saw before. I never saw this particular doctor wash his hands. You know, as soon as we came out the room, they asked me to do a survey if the doctor washed his hands. I'm like, ain't this some stuff?
Mm-hmm.
Like, this guy never washes his hands. So I was kind of wondering, like, why all of a sudden today? What happened?
Ooh.
All right, so we talked about this stuff, having personal attributes and the blended competencies. Now, here's those other skills I was telling you about. All right, so cognitive competencies, all right? So that's that critical thinking, getting a good knowledge base, knowing not only the information, but also knowing where to get those resources, those additional resources that you need your patient to reach out for, or that you might need to refer your patient for. Technical competencies. So this is like using equipment. Do you know how to use all the equipment on the floor? The IV pumps, the blood pressure cuffs, all that stuff. You know, as you become an RN, you're going to have a lot more exposure to equipment, some stuff that you may have never seen before. I've already rode down the road watching YouTube videos because I'm going somewhere and I got to use some piece of equipment that I've never seen before. And that's a great thing about YouTube and most of the companies like, let's say like KCI wound vac. You guys familiar with that?
Yeah.
So KCI actually has on their site how to put one of their wound vacs together and use it, which is pretty important for KCI because if anybody's ever used one of their wound vacs, you already know. If that wound vac is not on there and doesn't have a perfect seal, that is going to be your worst nightmare, right? Because all that pump is going to do is beat all day long, right? So the most important thing about this pump is knowing how to get a good seal. Now, once you learn it, you'll never forget it. You get it right. There's a little trick you have to use. And you get this trick when you deal with experienced nurses because they show you how to do something called window painting. And when you window paint these wounds, you rarely ever get a beep and pump. And it protects the skin more. All right, so we develop these technical competencies, and that's what those are, what I just talked about. That's all these technical competencies. All right, and then we develop interpersonal competencies, which means we learn how to establish these caring relationships where we're able to provide a certain amount of care to the patient and not go over the line and not allow them to come over the line. Because sometimes they'll try to come over the line because they feel this sense of, I guess, where they owe you something, okay? Especially if you saved their life. They feel like they owe you for that, all right? And you might not get that type of feeling from a patient in the hospital, but when you stop alongside the road, or, you know, it's your next door neighbor who just had a cardiac event and you go over there and save their life, you'll get more of that from them where they want to kind of cross over that line and pay you back more than what you really deserve because you were really just doing your job and you were just showing that you care. You didn't do it because you wanted a reward or payment. You enjoy the rewards of that mutual exchange because you're passionate about what you do and you enjoy and love what you do. You know, nursing is really not a monetary thing. For people that think that it is, they should probably take a second look at it because it's not. You don't get paid enough for the sacrifices that you make, but it's not about the money for most of us. It's, you know, a decent paycheck. It's not a great paycheck for everything that you have to go through to become a nurse and for everything that you have to go through being a nurse. We develop ethical and legal competencies, okay? And we're held liable for those competencies. So QSN, EN competencies center around these patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. So the goal is to meet the challenge of getting nurses ready, or future nurses especially, to make sure that they have the knowledge, the skills, the attitude, and the other components that they need to help improve the quality and safety of the healthcare system in general. And it's especially at the areas where they particularly work. Everybody's good with these terms here. Everybody knows about all these terms. We did talk about them a little bit before. Is anybody unsure? Okay, so we use different types of problem-solving methods as well as the nursing process. Trial and error is one type of problem-solving. You have to be careful with this, okay, because it's dangerous and it can cause harm to the patient. But we try different solutions until we find one that's effective. This is not really recommended for nursing practice, okay? Scientific problem solving, where we use the 7-step process with the problem identification, data collection, hypothesis, the plan of action. We interpret the results and we evaluate. Intuitive problem solving is where we have a direct understanding, but we also have some sort of background experience and knowledge and a skill, and we're able to make an expert decision based off of that. You might see this like in a recovery room nurse who is thinking that a post-op patient is deteriorating before there's signs to suggest problems. Now, we saw that yesterday in a question, or whatever day we did the questions, right?
Yes.
That was one of the questions we looked at.
Mm-hmm.
Okay. Critical thinking. Is it intuitive? Is it logical? Or is it both? So, yeah, it involves intuition, it involves logic and creativity, right?
Mm-hmm.
Okay. So we can actually develop the method of critical thinking that we use through purposeful thinking, through acquiring knowledge, through being able to identify potential problems, using available resources, and by having our decisions critiqued or our judgments critiqued. And somebody may have asked you about that, you know, when you were getting your interview for school. They may have said to you, I may have said that to you, you know, tell me about a time when your work was critiqued and how you responded to that. Okay, because why is that important? Well, when people critique our work, they help us to become better sometimes. Sometimes they help us to see faults that we don't see ourselves. If you work in a facility and you're part of like a code team or something like that, when we run codes at my facility, we have a safety and emergency committee. So after the code is done, then we go back and we look at the documentation from the code and we talk about everything that was done in the code. We look at risk factors, ways we could improve running the code, and things that we could do better that may have had a better outcome for the patient. Sometimes we have errors when we make decisions. And remember, I said that to make an error, I mean, as nurses, we sometimes do that. If you make an error and the patient dies, you're probably in good shape because, you know, that's the best thing sometimes that can happen to them. Sometimes you make an error and your patient ends up in a worse situation than what they started out in. That can be pretty sad. Sometimes things that can cause us to make errors are being biased. So I see my patient fall out and I just automatically assume that their blood sugar dropped. I don't give consideration to anything else. Really, they could have had a syncopal episode. Other things could have happened, right? They could have had a stroke. We don't know. The blood pressure could have just dropped. But if we think in one realm or one way of thinking, then that causes us to make a potential error, and it could be a fatal error or something worse. We don't consider the total situation. So we don't put all the pieces of the puzzle together and then analyze it and methodically think it out. Or we're impatient. We don't want to give the patient's body a time to respond, or we jump to a rush in judgment. So, you know, creative thinking itself uses imagination, intuition, spontaneity, things that help create the art of nursing. So you can have a little bit of, you know, thinking of your own mind. And it's good for you to have that creative thinking and bring it into play. You know, why? Why not? You know, you want to ask questions and get to the bottom of solutions and think about other ways that we can resolve things. You want to think outside the box and imagine consequences or how an outcome could be. And when you think of those realms, it will also help you answer questions, because when you ask the question and then you look at the answers, you know, before you pick an answer, think about, if I pick this answer, how's this going to change, or what's this going to make the outcome be? So this is just talking about a little bit of the history of the development of nursing. I'm not going to go into it too much. It just tells you about the nursing process, mostly a little bit about the board exams and when nursing practice developed. So the nursing practice itself became a little bit more complex in the 20th century when nurses actually began to study the process of nursing and understand how it can improve the way nurses are able to accomplish their aims. And in the 60s, theorists started to describe nursing as a distinct entity. And then those other things came into play in 1967. The first comprehensive book came out on the nursing process, and it talked about 4 steps: assessment, planning, intervention, and evaluation. And the nursing diagnosis itself was looked at as a logical conclusion during the assessment phase. And then these and other studies led to developing the 5-step nursing process that's used today, which is the assessment, diagnosis, outcome identification and planning, implementation, and evaluation. So these processes were legitimatized in 1973 when the American Nursing Association went to Congress and had all this made legal. So the following definition serves as the foundation for the scope and standards of nursing practice. Nursing is the protection, promotion, optimization of health and abilities, prevention of illness and injury, alleviation of suffering through diagnosis and treatment of the human response, and advocating for the care of individuals, families, communities, and the population. So we use these 6 standards of practice: assessment, diagnosis, outcome identification, planning, implementation, and evaluation to help describe a competent level of nursing care that is supported by critical thinking model and the nursing process. So the 5 steps, again: assessing, diagnosing, planning, implementing, and evaluating. We refer to this as ADPI. During the assessment process, we are collecting data, validating that data, and communicating that patient data. Diagnosing, we are analyzing that patient data and trying to identify the patient's strengths and their problems. Then we plan, okay? And we plan according to what we want for that patient. What kind of outcomes do we want for that patient? And how are those outcomes related to the nursing intervention? So you see why in the care plan, I keep saying the things have to be married together. One thing goes with the other, okay? The left shoe goes with the right. Otherwise, you'll be walking around in circles because you got 2 left shoes on, right? So when people ask me if I'm all right, I say, no, I'm half left, because if I was all right, I'd be walking around in circles. Tough crowd tonight, boy. I expect at least a tip at the end of the night if I'm not going to get any laughter at my jokes.
It's Losh, I'm laughing and my phone just on mute.
Okay. And when we're evaluating, we're measuring the extent to which the patient achieved their outcomes. So, you know, this is all stuff that you're doing in that care plan. And if you just think about it in the nursing process, it won't be so hard for you to implement it.
We was laughing, Miss Loesch, but we on mute, so by the time we take it off mute, your joke is over.
Oh, okay. As long as you were laughing. All right. So again, this just talks about, you know, the steps and how they are related to each other. You know, they intertwine and they go together. So even though the ANA calls it a 6-step nursing process, mostly everybody else still refers to it as the 5-step.
Ms. Loesch, did you do the 10 questions already for the that you said we're going to go, that we're probably going to be on the midterm?
I didn't go
Never
over
mind.
10 questions that are going to be on the midterm. I don't know what's going to be on the midterm as far as question-wise. We all submit questions. All the instructors submit questions, but we don't see the exact exam.
Oh, okay.
Yeah, but I would just know as much as I can know. And if you go through this stuff that I sent you with your lecture notes and those questions in the book, okay, you're doing your prep view, we should be getting you there. Plus, I'm going to do 2 more reviews. I'm going to do one on Saturday and another one either Sunday night or Monday. I'm thinking it's going to be Monday.
Okay. Oh, thank you.
Okay, because
Monday we have our
You have time on Monday, you're studying for nutrition on Tuesday.
So no, those of us who have English on Monday, we have a midterm Monday.
From 4 to 6, right?
Yeah.
So Sunday will be good.
Yeah.
Okay. Let me see what I can do for Sunday then. Also, I'm recording this one today, so I intend on recording the other ones too. And if I can easily convert them into the YouTube links, I'm going to put them up.
Okay.
Just took me a long time to convert the last one, but I think it's because I ended up recording it on the school computer and then it was acting all kinds of funky on me. I was like 6 hours to convert that video and it was horrible. But it's up there. And I hate myself on video, by the way, but if it works for you guys, I'm good, I guess. I have to suffer. Okay.
Okay.
So, you know, characteristics of the nursing process. For one, it's systematic, right? We have this ordered sequence of activities and it goes through this sequence. It's dynamic. So we have this great interaction and overlapping among the 5 steps. It's interpersonal. So the human being is always at the heart of it. The outcome, it's outcome oriented. In other words, we work together to try to identify potential outcomes. Hopefully outcomes that are going to make it better for the patient. And then it's universally applicable. So it's a framework that we can use for all nursing activities. So, you know, this nursing process benefits the patient because besides giving them this evidence-based scientific care, it puts a holistic view on the patient and it provides continuity care. It also provides clear, cost-effective, and efficient care to the patient. For the nurse, it gives them an opportunity to work collaboratively with other healthcare providers. It gives them satisfaction in knowing that they made a difference with their patient's life. And it gives them an opportunity to grow professionally. So according to Schmel, we have a few basic steps, and these are part of the concept map care. So for the concept mapping, we need to collect the patient problem and their concerns on a list. Then we connect and we analyze the relationship between the problems and the concerns and the data that we have. We can complete a diagram, and then we try to keep in mind the key concepts, which are the nursing process, that holistic care, safety, and advocacy. So when we make that list for the patient problems and concerns, it can include things like symptoms, lab values, diagnostic testing, treatments, or collaborative care concerns. And this can be obtained from the nurse, the patient, the medical record, or from interactions with other people on the team. We can connect and analyze the relationships and differentiate between different groups of main and related problems. And we can ask questions, we can compare and contrast data that's there. We can also create a diagram that demonstrates the problem recognition, critical thinking, and actions of nurses. We can use things to connect, you know, one concept to another, descriptive phases. And these concept maps, as they become more concept, we can even make a key if we wanted to keep track of like the boxes, the links, and the colors, and what it actually represents. So when you develop one of these concept maps, creativity is encouraged. No 2 concept maps will look the same. And we use the key concepts of the nursing process, holism or holistic care, safety, and advocacy to make them. I want to go. I can get out and go on that bike. Okay, reflection and action. So this is happens right in the here and now, okay? It's called thinking on your feet. So, you know, you see somebody fall to the ground, or you're driving down the road, you see a car crash in the woods, you just act, right? You don't stop and think about it, you just do it. If it's on action, then it occurs after the fact, and it involves thinking through a situation that occurred in the past. And reflection for action is helping the person think about the future actions that might change as a result of the reflection. So we have reflection in action, which is like thinking on your feet, on action, which happens after the fact, and then for action, which helps us think about future actions. For these concepts maps, they're sometimes called cognitive maps, mind maps, or metacognitive tools for learning, and they help us promote critical thinking and self-directed learning. So that's the main reason why we do them. So why do we do reflective practice? Because it's purposeful. It usually will lead to some sort of an action. It could lead to improvement in practice, better patient outcomes, and it helps us understand the processes and things that we're working with. So these three things here are three types of reflection. This is according to Sean, and it's called Gibbs' model of reflection. Let's go 14, get up here. You're up. Okay, what happened there? Not sure. Let's go back here. Grab it because it's not letting me pull it from there. Okay, so you should be able to describe the 5 types of nursing. What the heck? Okay, I'm like, what I do now, silly? All right. Make sure you're able to describe the 5 types of nursing assessment: initial, comprehensive, focused, emergency, time lapse, and then assessment of communities and special populations. And you should also be able to tell what the purpose of each assessment is and how they're performed. So for the initial assessment, it's a comprehensive nursing assessment, and you're going to get your baseline data. It helps the nurse make a judgment about the patient's health status, and it gives the ability to manage one's own health and need for nursing. Also for the nurse to plan individualized holistic care to the patient. For that focused assessment, it's going to be conducted to assess a specific problem. So like we think our patient has a cold, we're going to do a focused assessment on them. And we would correlate that assessment around the things that we would expect to find in a cold, right? So you might listen to the lung sounds, you might check them for a runny nose, you might check them for a temp, but you don't care about their life history, all right? Because you're checking them for a focused assessment for a cold. It focuses on pertinent history and body regions, but also the immediate and highest priority of concern for the patient. The emergency assessment, this is a rapid focused assessment, and it's done when assessing a life-threatening or unstable condition. We have the time-lapsed assessment. This is scheduled to compare the patient's current status to the baseline, done earlier. So what is the relationship between the nursing assessment and the medical assessment? So medical assessment. Go ahead.
Is one the doctor gives a medical assessment and then the nurse is doing the one?
Well, medical assessment really goes towards that pathological condition, whereas the nurse focuses on what the patient's response is to that condition.
Okay.
So like when you go in to see the patient, right, you're not going in to see them because they're having a heart attack. You're going in to see because they're having pain. There's an interruption in the blood flow. They're not breathing well. You know, they have some sort of issue going on, right?
Uh-huh.
And so you're going in there to treat that issue. Like when they take a medication, what are you treating? You're treating those side effects of that medication, right? The dizziness, the dry mouth, those patient complaints. So the real difference between the medical is that it actually targets the pathological condition, whereas a nursing assessment focuses on the patient's response to the health problem. For the emergency assessment, that's a rapid one. That's conducted when we have a life-threatening situation. And then time lapse is when we are scheduled to compare one baseline data to another one that was obtained earlier. So we would want our nursing assessment to be purposeful. So we have a reason why we're doing it. It should be prioritized, meaning that we're looking at the most significant issue now. It should be complete, systematic. Systematic gives us a direction to go in, so we're not all over the place. It should be factual and accurate, not based on assumptions or what we perceive or what we think. And then it has to be relevant. Also, it should be recorded in a standard manner. Whoa. All right, so those are your 5 types of nursing assessments. I just went through them. Everybody good with those? Anybody have questions?
No. No, I'm good.
All right, so the initial one is right after the admittance to the hospital or during the, process thereof. We're going to get a complete database for the problem identified and care planning. And then it's going to be done by the nurse. We're going to collect data on all aspects of the patient's health. They're being admitted to the hospital. We need to know as much about them as we possibly can. This focus one, okay? You're focusing in on the priority problem or the initial problem, maybe why the patient came there today. Emergency, this is due to the physiologic or psychologic crisis, all right? You're identifying life-threatening problems and you're gathering data about a life-threatening problem. The time lapsed, where you're comparing one baseline to what the current status is. And then medical versus nursing. The medical is targeting the pathologic. The nursing is focusing on the patient's response. All right, objective data. This is stuff we can observe, stuff we can measure. It can be seen by you or felt by somebody other than the patient. So examples are elevated temperature, moist skin, vomiting. Subjective data is stuff only the patient or only the person that's affected can perceive it or see it or feel it. So where do we get our data from? The patient, significant others, patient records, consults, lab reports, diagnostic studies, therapies, nursing, other healthcare professionals, or literature. And the nurse that's observing has to have skills. She's got to be able to determine what the patient's current response is. Is it physical or emotional? What is the patient's ability to manage their care? So in your particular case with the case study, doesn't appear to be too good. He's not doing too good of a job of managing his care. Determines the immediate environment and its safety. So, is your patient safe? Is the environment safe? Is everything about this situation safe? And determines the larger environment, hospital or community. So a couple things, you just want to make sure that when you're gathering this data, organizing and gathering this data, that it's purposeful, factual, complete, accurate, and relevant. All right, because if it doesn't meet that criteria, then it doesn't belong there. So we're appraising the health status for this physical assessment. We're looking at the response to the health problems. We're establishing a database for our nursing interventions that we're eventually going to create, and we're gathering objective data.
What do they mean by appraisal of health status?
So you're looking at the overall health status of the patient. Sometimes a patient comes in and you start looking at them, you look at their chart, you look at what their vital signs and stuff are, and you're like, how are they even standing here? Right? And then you look at other people and you're like, how are they even sick? They look like a complete picture of health. So you're looking at the overall health status and you're evaluating it.
Okay.
right, so use that clinical reasoning. This means that you're looking at things systematically and comprehensively. You really have to understand the human body, because you could do one thing wrong in the human body and it could cause a domino effect. So you just want to make sure that you know what you're doing. You're detecting bias and determining the credibility of your information sources. You're distinguishing normal versus abnormal findings and identifying the risk for the abnormal findings. So if my patient's heart rate is going at 150 beats a minute, I know that that patient could have a heart attack if I don't stop or decrease the workload of that heart. So that would be a risk for an abnormal finding. Making judgments about the significance of the data, distinguishing relevant from irrelevant, identifying assumptions and inconsistencies, checking accuracy and reliability, and recognizing the missing information. So, you know, we're going to have problems if our database isn't organized, if we omit certain information, if we include irrelevant duplicate data or data that's either erroneous or misinterpreted, if we don't establish a rapport and a partnership, and if we don't update the database after changes in the healthcare status. So, you know, I'm a person, I know for a fact I can get more flies with sugar than I can with vinegar. So I'm going to make alliances with everybody out there that I have to partner up with. Why? Because when I need something, I can get it from them. When they need something, who are they going to come to? Me. All right? And you can get stuff. Like during this whole COVID thing, this is how I got some of my PPE. This is how I got body bags to put my patients in, by willing and dealing with other people that you've established this rapport and relationship with. And the same thing, they were able to give me certain things and I was able to give them certain things. And we were able to meet each other's needs during that process because of this rapport that you've developed with them. So if there's a discrepancy between what the person tells you and what you see, then you need to verify that data. So what does that mean? My patient tells me they don't smoke and I see them outside smoking. Maybe my patient tells me they don't have high blood pressure, but when I go back and look at the chart 5 years ago, I see that they were being treated for it. Okay, so, you know, you just want to make sure that if the data is not credible, that you try to verify it. And sometimes people aren't trying to mislead you. They just don't remember, or they're timid. They don't want to say it because they're timid or shy about it. And there's other reasons also too sometimes. So we have to be ethically responsible, safeguarding privacy of patients. Okay, you're going to have access to not just patients, but a lot of important information for the patient. And right now in this country, we already got people hacking and stealing information left and right. So you as a nurse want to make sure you're protecting that patient as much as you possibly can. Make sure you're aware of the policies at your facility as well as the HIPAA Act. And there's a couple of other sites there that you can get guidelines on social media. My nurses at my job violate this all the time. I'm constantly on them about this because they think they can put stuff on Facebook, all right? And they don't put names, and they don't have to. Because if you have 500 or 600 people that work there and you put certain things on Facebook, you're not the only person that knew that person for 20 years. So what you're putting on there isn't a secret. Anybody that knows that person will be able to figure out that's who you're talking about because you're putting identifying markers on there that other people are aware of. So it's not just saying their name, their date of birth, and stuff like that. It's actually saying anything about that patient. And if you put anything on Facebook about that patient where someone else can identify that patient, it's a HIPAA violation. All right, phases. These are just the different phases. And it's just like a way of you to figure out the diagnosis, like a methodical way of doing things. So we're collecting the data, we get these cues, and we make inferences. So that means you're looking at the data after you've collected it, and you're thinking, oh, the sodium's a little high, so maybe blah, 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 blah. Okay, that's what they're doing here. All right, they're validating the data, and then they're going to take data that's alike, and they're going to cluster it together and try to identify patterns. Well, if you know your disease processes and stuff, that's how you do this. So maybe the patient's got 3 things that leads the nurse to believe that they're iron deficiency anemic. Or maybe the patient's got 3 things to lead the nurse to believe that there's a GI bleed. So, you know, it's using this clinical reasoning and that assessment data, and you can start to try to formulate your diagnosis. What happened? Okay, I think I got it there. All right, so documentation. Immediately, you're going to give a verbal report of data anytime there's an immediate change in the patient's status, okay? Especially if it's a critical change, all right? And this is really based on your hospital policy, but if it's a critical change, you're going to tell somebody, all right? In the database, you need to enter into the computer or record in ink anything about the patient that happens right away. It says enter the patient into the database the same day. Yes. Summarize objective and subjective data in concise, comprehensive, and easily retrievable manner. So make sure it's makes sense, that it, you know, is legible, that people can understand what you're saying. Use good grammar and standard medical abbreviations. You can't just make up any kind of abbreviation you want. You got to use standard ones, or generally the facility requires that you use abbreviations that are approved there. And they usually have a book, and in the front of that book will have all the abbreviations that you're allowed to use or not use. And then whenever possible, use the patient's own words and avoid non-specific terms subject to individual interpretation or definition. All right, you guys, I got to go to my L to R meeting. I'm willing to come back on here for like another hour around 9:30 if anybody is interested.
9:30? Okay.
Yep. So I will just open the link back up. Now, if I have a meeting with you at 8:40 or whatever, I'll be there. Because there's a couple of people I have meetings with. So if I have a time to meet with you, just use the link and I'll be there. I'm going to close this link out and I will resend.
Wait, so you gave us the code of the day already?
I did.
My dad is really loud in the background, so if you did in between everything, I probably didn't hear you.
What's up? What's
You'll
up?
You say
What I'm
coming
going
back
to do is I'm going to send you guys a Zoom link for 9:30 for anybody who wants to come on. If I come on earlier, then I'll send an email and say, come on.
Okay.
Ms. Loach, don't forget to send the example of the care plan.
Oh, yeah.
Of the care plan and that stimuli thing, right?
Yeah.
Yes.
Okay. No problem.
Thank you.
All right. Thank you.
All right.
Thank you.
See you guys in a little while.
All righty.
Good night, all.
Good night.
Night.
Good night.